Hello and welcome, fellow student doctors. Today, we will learn about cranial nerve reflexes by applying them to a clinical scenario, declaring a patient brain dead. By medical and legal definitions, the patient must have suffered irreversible brain trauma that results in the loss of brain and brainstem functions to be declared brain dead. There are three key domains to evaluate. 1. The patient is in a coma. 2. The patient cannot breathe on their own. And 3. The patient has an absence of brainstem functioning, which is assessed by testing cranial nerve reflexes. Student doctors, learning this material is literally the difference between declaring a person alive or dead. Once you realize the magnitude of the content you are studying, it no longer becomes studying. It becomes the practical application of materials that are critical for every future physician to know and understand. With that thought in mind, let's go ahead and get started. To prepare you for test day, you will be able to 1. List the cranial nerves present at each level of the brainstem. 2. Describe normal and abnormal cranial nerve reflexes. And 3. Explain how to test cranial nerve reflexes when evaluating a patient for brain death. This image of the brain, brainstem, and cranial nerves will guide our discussion. First, you must understand the rule of 4 to organize the 4 cranial nerves that exist at or above each level of the brainstem. For example, cranial nerves 1 through 4 are located in or above the midbrain. Specifically, cranial nerves 3 and 4 are in the midbrain. Cranial nerves 5 through 8 are in the pons, and cranial nerves 9 through 12 are located in the medulla. As you can see, there are 4 sets of cranial nerves per level of the brainstem. So, to test the health of the brainstem and its cranial nerves, we use cranial nerve reflexes. Let's start with the pupillary light and accommodation reflexes that assess the health of the midbrain. Let's start with the pupillary light reflex. As background, all reflexes are involuntary and have afferent and efferent pathways. The afferent limb of a reflex arc involves sensing a stimulus. The efferent limb of a reflex arc involves a response to that stimulus. Just remember that afferent A arrives, like a sensation arriving to the CNS, and efferent E exits, like the response exiting the CNS. With that in mind, this diagram will demonstrate the parasympathetic pathway that causes meiosis, or constriction, shrinkage of the pupil. I cover this in more detail in our module on pupillary control, but for our purposes here, know that everything in purple is under parasympathetic control and that pupillary constriction is mediated via the sphincter papillae, the purple circle around the black pupils. To test this reflex, light is shown into either eye, which is sensed by the retina and transmitted via cranial nerve 2, the optic nerve, to the midbrain's pretectal nuclei. Each optic nerve, cranial nerve 2, sends projections bilaterally as nerve fibers cross from each eye in the optic chiasm and then project to both pretectal nuclei. With light signals coming from both eyes, the pretectal nuclei send projections to the Edinger-Westphal nuclei in the midbrain. These nuclei contain preganglionic parasympathetic neurons. Importantly, the pretectal nuclei, like cranial nerve 2, sends projections bilaterally to the Edinger-Westphal nuclei. Another important crossover in this pathway. This is the afferent limb of the reflex arc. In terms of the efferent pathway, preganglionic parasympathetic fibers from the Edinger-Westphal nuclei hitch a ride on bilateral cranial nerve 3, the ocular motor nerves, fibers to the ciliary ganglia. Cranial nerve 3 is partially purple because it carries both parasympathetic fibers but also motor fibers to control extraocular eye movements. The ciliary ganglia houses postganglionic neurons that synapse with the preganglionic parasympathetic fibers from the Edinger-Westphal nuclei. From the ciliary ganglia, short ciliary nerves, which are postganglionic nerve fibers, project to the sphincter papillae muscles of the iris to release acetylcholine onto muscarinic receptors to cause meiosis, pupillary constriction of both eyes. Overall, there are a few key points to know. The short ciliary nerves shorten or constrict the pupil. Secondly, there are multiple crossovers in this pathway, as cranial nerve 2 and the pretectal nuclei send projections bilaterally. This is important because these crossovers explain the indirect consensual pupillary light reflex, such that light shown directly into one eye causes constriction indirectly in the opposite eye. Lastly, if a patient's pupil constricts when exposed to light, then what area of the brainstem is healthy? The midbrain, where cranial nerves 2 and 3 interact. Resetting the pupils, if light is shown into either eye and the pupils do not constrict to light, then the midbrain may be declared dead. Moving along, the accommodation reflex also uses cranial nerve 2 for its afferent limb and cranial nerve 3 for its efferent limb. Rather than going through all its neural pathways, I want to cover its most high-yield application: Argyll-Robertson pupils, which occur due to tertiary syphilis. Specifically, the term Argyll-Robertson pupils refers to bilateral small pupils that do not constrict to light, only to accommodation. Let me explain. Starting with testing the light reflex, when light is shown into either eye, the pupils do not constrict. So the pupillary light reflex is not working. The midbrain is damaged. How? Syphilis can damage the pretectal nuclei, impairing the normal pupillary light reflex. However, the pupils will constrict if the accommodation reflex is elicited. To elicit the accommodation reflex, you would ask the patient to follow your finger as you move it towards their nose. That is, we ask them to look to the middle and focus on our finger. Now, watch the pupils. This is a normal accommodation reflex. That is, the pupils constricted as the eyes converge to focus on a near object, your finger. The accommodation reflex is intuitive, friends, because the pupils need to constrict to focus the light rays from a near object onto the retina so we can see them. Cranial nerve 2 senses those light rays and sends projections throughout the cortex. The cortex then sends signals through the brain, brainstem nuclei, and to cranial nerve 3 to converge the eyes inward, to constrict the pupils to focus light, and to thicken the lens via the ciliary muscles to focus the light from a nearby object. Overall, the key thing to know is that Argyll-Robertson pupils exhibit light near dissociation. That is, the pupils do not constrict to light due to the pretectal nuclei being damaged by syphilis. However, the pupils do constrict when the accommodation reflex is elicited because it uses the cortex and various other brain and brainstem pathways. With a brain death candidate being unconscious, this reflex is not used in their assessment. Lastly, to help you remember this condition, on the wards, you may notice that patients have in their chart PERLA or P-E-R-R-L-A listed. This notation denotes a normal pupillary exam, where the pupils are equal, round, and reactive to light and accommodation. Here, the pupils are equal and round, but are not reactive to light, only to accommodation. Now that we've covered the reflexes to assess the health of the midbrain, let's cover the reflexes to assess the health of the pons. The corneal reflex assesses the health of the pons and uses the V1 ophthalmic division of the trigeminal nerve, cranial nerve 5, for its afferent limb, and cranial nerve 7, the facial nerve, for its efferent limb. Looking at this image, you can see the three divisions of cranial nerve 5, and that V1 is sensory to the upper face and eye. To elicit the corneal reflex, a Q-tip can be used to lightly touch the patient's right cornea, see in this image. This is sensed by the right V1 division of the trigeminal nerve, specifically the nasociliary branch that carries information to the right cranial nerve 5 trigeminal sensory nucleus in the pons. From here, the right cranial nerve 7 or facial motor nucleus in the pons is activated and sends efferent or motor response along the temporal branches of cranial nerve 7 to the orbicularis oculi muscles. a circular muscle represented in red here that acts as a sphincter of the eye to close the eyelid, as shown in this animation. Think about it. If your cornea was touched by something from the outside world, you would want to shut that eyelid pretty quickly, to limit damage. This is referred to as the direct response. Just like the pupillary light reflex, we have a direct response to the stimulus from the stimulated eye, the right eye here, and an indirect response that mirrors that eye. Here, the indirect response will be the left eyelid closing in conjunction with the right eyelid closing. Let me show you. The stimulated right cranial nerve 5 sensory nucleus activates the left cranial nerve 7 or facial motor nucleus in the pons, which sends signals along cranial nerve 7 to the orbicularis oculi to close the eyelid. Resetting our animations, if the patient's cornea is touched and no response is observed, the pons may be considered dead. The lacrimal reflex assesses the health of the pons and uses the V1 ophthalmic division of the trigeminal nerve, cranial nerve 5, for its afferent limb and the facial nerve, cranial nerve 7, for its efferent limb, just like the corneal reflex, which makes sense looking at this dermatome map of the trigeminal nerve. As you will see in this diagram, the corneal and lacrimal reflexes work together to close the eyelid, to limit damage to the cornea if it is touched, and lacrimation or tearing to wash away foreign substances if they are present and touching the cornea. So, both the corneal and lacrimal reflexes can be elicited by touching the cornea of the eye, here the right eye. The right V1 nasociliary branch transmits this information to the right cranial nerve 5 sensory nucleus in the pons, which then activates the right facial nucleus. Cranial nerve 7 then activates the orbicularis oculi to close the eyelid. That is the corneal reflex. In the same pathway, the right cranial nerve 5 nucleus activates the right superior salivary nucleus that sends parasympathetic fibers along cranial nerve 7 to exert the efferent limb of the lacrimation reflex, that is, tear formation. That is the direct response to the stimulus, the Q-tip touching the right eye. The indirect response to the stimulus is the opposite eye closing its eyelid and producing tears, which occurs by the activated right cranial 5 nucleus activating those same pathways on the left side to close the eyelid and produce tears. Interestingly, the superior salivary nuclei receive several inputs that can elicit tear production, such as from pain, emotion, thoughts, and other voluntary actions or involuntary reflexes. Due to these complexities, the corneal reflex is more suited to test the health of the pons when evaluating brain death. The jaw jerk reflex assesses the health of the pons and uses the V3 or mandibular division of the trigeminal nerve for its afferent limb and efferent limb, which makes sense looking at this diagram for the trigeminal nerve. Importantly, and listen closely, the trigeminal nerve is sensory to the face and motor to the muscles of mastication or chewing. Move your jaw up and down and do a chewing motion. That is cranial nerve 5. Now smile really, really big. That is motor from cranial nerve 7, which supplies the muscles of facial expression. Now say it with me. Cranial nerve 5 is motor to mastication. Cranial nerve 7, also called the facial nerve, is motor to facial expression. Got it? Good. Please don't forget this. So many people screw this up, but just remember that the V3 branch of the trigeminal nerve is called the mandibular branch. So it controls the mandible. So that is one way to think about it, and I hope that helps you. Now, to test the jaw jerk reflex, we need to stretch the masseter muscle. This can be done by tapping the chin of a patient whose mouth is slightly open. This stretches the muscle spindle within the masseter muscle, which is essentially a molecular spring to detect the stretch of a muscle. Think about it. If a muscle is stretched too far, it will rip or be damaged, right? So the body developed a reflex to quickly shorten the muscle to avoid it being ripped. Hence, the reflex arc jerks the jaw back together. Let me show you. The muscle spindle signals via the V3 sensory mandibular branch fibers to the sensory neurons in the cranial nerve 5 mesencephalic nucleus in the pons. This activates the efferent limb of the reflex by activating the cranial nerve 5 trigeminal motor nucleus that sends motor fibers along V3 back to the masseter muscle to cause the muscle to contract. That is, it causes the jaw to jerk upward. Overall, the absence of this reflex may indicate that the pons is dead. The vestibular ocular reflex uses cranial nerve 8 in the pons for its afferent limb, and cranial nerves 3 and 4 in the midbrain, and cranial nerve 6 in the pons for its efferent limb, as these nerves control eye movements. The easiest way to understand this reflex is with an example. Look at this cat. Now, continue to look at the cat, but move your head side to side, up and down, and in a clockwise motion. No matter how you move your head, the cat remains in the center of your vision as your eyes continually center it. How does this happen? Cranial nerve 8 senses head movements, and cranial nerves 3, 4, and 6 move the eyes to adjust. Here is a diagram of what your eyes were doing as you kept that cat in the center of your vision. To continually center an image, the eyes move in the opposite direction of where the head moves. If the person looks to the right, see how their eyes go left. If the person looks left, their eyes go to the right, as you can see. Let me share my own cheat code to remembering this reflex. Each cranial nerve 8 moves the eyes to the opposite side. Look at this image. If the head moves left, the left cranial nerve 8 activates to move the eyes to the right. Let me walk you through this example. If the person looks to their left, the left cranial nerve 8 becomes activated and the right cranial nerve 8 becomes inactivated. Following the left cranial nerve 8 pathway, the left cranial nerve 8 nucleus in the pons becomes activated and signals the right cranial nerve 6 nucleus in the pons to send signals via the right cranial nerve 6 to the right lateral rectus eye muscle to turn the right eye to the right or to abduct it via cranial nerve 6, the abducens nerve. The right cranial nerve 6 nucleus in the pons also sends signals via the MLF, the medial longitudinal fasciculus, to the left cranial nerve 3 nucleus in the midbrain to activate the left medial rectus eye muscle to turn the left eye medially or to the person's right. As you can see, if the person's head moves to the left, the eyes move to the right. This complex neural pathway shows the true value of the cheat code. Just know that each cranial nerve 8 turns the eyes to the opposite side. If the right cranial nerve 8 becomes activated, the eyes should move to the left. If the left cranial nerve 8 becomes activated, the eyes should move to the right. Just use that simple opposite rule. Now, let's apply our knowledge to a highly testable condition, vestibular neuritis. So how do we assess this patient to determine if they have vestibular neuritis? Well, you would use the head impulse test by physically moving the patient's head quickly to the right and then watching their eyes. These eyes show an abnormal vestibular ocular reflex due to a defect in the right cranial nerve 8. When the head impulse test quickly moved the person's head to the right, the eyes didn't move to the opposite side, the left. They just passively followed to the right with a saccade or quick movement back to the center in the far image. This represents right cranial nerve 8 dysfunction. Now, for our last clinical correlation, the doll's eyes test. Watch this animation as the person's head is moved. The eyes will passively follow the direction of rotation because the brainstem, the midbrain and/or pons is damaged and cannot cause the eyes to look the direction opposite of rotation to center images. See, the eyes roll passively with rotation of the head, like the eyes of a toy doll. In an unconscious patient, you would attempt to observe this by opening their eyelids and gently moving their head in different directions, assuming they have no cervical spine concerns. The vestibulo-ocular reflex is a difficult one to learn. I listed descriptions under these to help you study. The vestibulo-ocular reflex is so high yield, so let me tell you about caloric testing in unconscious patients. To activate or inactivate cranial nerve 8, you can put warm or cold water in the ear of a patient respectively. Starting with warm water caloric testing, represented by the red container of water entering the patient's left ear, this activates the left cranial nerve 8. How? Warm water creates a certain current within the semicircular canals that is equivalent to looking to the left, activating the left cranial nerve 8. So all this circuitry becomes activated just like in our example. The left cranial nerve 8 in an unconscious patient can be activated by putting warm water in their left ear. This causes their eyes to move to the opposite side to the right as shown. If their brainstem, the midbrain and pons, is intact, this will also produce nystagmus, where the eyes will rhythmically beat to the right as shown and then quickly snap back to center. The eyes will alternate back and forth. If the brainstem is dead, the patient's eyes will not move and there will be no nystagmus. Now, caloric testing with cold water inactivates cranial nerve 8. Pictured here, the unconscious patient is receiving cold water in their right ear. This is equivalent to the patient looking to the left as pictured here, with all that circuitry becoming activated. Why? By putting cold water in the right ear of the patient, this inactivates their right cranial nerve 8. In turn, this leads to relative activation of the left cranial nerve 8, so the patient's eyes should turn to the right if the brainstem is intact. This will lead to nystagmus, as the eyes slowly move to the right and then quickly back to center, like this. If the brainstem is dead, the eyes will remain in the center and no nystagmus will be observed. As a cheat code, know that warm water activates cranial nerve 8 and cold water inactivates cranial nerve 8. If you know those facts, then you can derive all the necessary information to score big on test day. Now that we've covered the reflexes to assess the health of the midbrain and pons, let's cover the reflexes that are used to assess the health of the medulla. The gag reflex assesses the health of the medulla and uses cranial nerve 9, the glossopharyngeal nerve, for its afferent limb, and cranial nerve 10, the vagus nerve, for its efferent limb. To elicit this reflex, a physical stimulus, like a tongue blade or suction device in an intubated patient, is applied to the posterior pharyngeal wall, tonsillar pillars, and/or base of the tongue. This activates, intuitively, the glossopharyngeal nerve, cranial nerve 9. Why is this intuitive? Because the name of the nerve tells you everything you need to know. Glosso refers to the tongue, and pharyngeal refers to the pharynx. So, if these structures are physically stimulated, it activates the glossopharyngeal nerve, cranial nerve 9, to send signals to the nucleus solitarius in the medulla. You may know that certain medications act in the nucleus solitarius to reduce nausea and vomiting. So it also makes sense that this nucleus is part of the gag reflex, doesn't it? Overall, the nucleus solitarius sends signals to the nucleus ambiguus, a motor nucleus in the medulla. This sets in motion the gag response, which involves coordinating cranial nerve 5 to open the jaw, cranial nerve 12 for tongue protrusion, and cranial nerve 10 to cause the pharyngeal muscles to contract. As you can see, the simplified cranial nerve 9 to 10 is a simplification for this reflex arc. But the boards really want you to understand that this assesses the health of the medulla. So ask yourself, if stimulated, does the person gag? If yes, the medulla is healthy and intact. If no, the medulla may be dead in the context of a brain death examination. Another very high-yield application of this reflex is as followed. Pictured is a mouth with a black outline and a red uvula hanging inside of it. If you elicit the gag reflex and the uvula deviates to the left, what does this tell you? It tells you that the gag was sensed by cranial nerve 9, the glossopharyngeal nerve, and that it is functioning. However, there is a motor or efferent issue. The right cranial nerve 10 is not working. Think about it. The left cranial nerve 10 contracted unopposed on the left side of the pharynx and then swung the uvula over to the contracted side, the left side. This may indicate a possible brainstem stroke. Where would this brainstem stroke be? The medulla. The cough reflex assesses the health of the medulla and uses cranial nerve 10, the vagus nerve, for its afferent and efferent limbs. Various triggers can be sensed by the cough receptors in the nose, sinuses, upper and lower respiratory tracts, heart, and even esophagus. These can be mechanical triggers, such as the pressure from built-up mucus or smoke and dust particles, chemical triggers like gastric acid reflux, and thermal triggers like cold air. Cranial nerve 10, the vagus nerve, transmits these stimuli to the medulla, which activates the nucleus ambiguus, a motor nucleus which exerts its motor effects via cranial nerve 10 to produce the cough reflex. However, when you cough, you use many other muscles not innervated by cranial nerve 10, such that the medulla activates the phrenic nerve and spinal nerves to recruit the diaphragm and abdominal musculature, respectively, into the cough reflex. Quickly, what are the nerve roots of the phrenic nerve? 3, 4, 5 keeps the diaphragm alive. Those are the commonly tested nerve roots of the phrenic nerves you must know for test day. To test this reflex in an unconscious patient, tracheal suctioning can be used. If the patient coughs, their medulla is intact. If the patient does not cough, their medulla may be considered dead. While not a cranial nerve reflex, I wanted to briefly mention the role of the medulla in respiration. For board exam purposes, the medulla houses the key centers for minute-to-minute respirations. So, spontaneous breathing is an excellent way to assess the health of the medulla in the setting of a brain death examination. This is performed with the apnea test, where mechanical ventilation is stopped. A period of time is then given to evaluating if the patient begins to breathe. If they do, the medulla is intact. If the patient does not begin to breathe on their own and CO2 levels rise, the medulla may be considered dead. We covered a lot of cranial nerves in this lecture. Be sure to know their foramina, as the boards will sometimes describe a cranial nerve or a cranial nerve reflex and then say the nerve involved exits what foramina in the skull. To help you with the most high-yield foramina, use the mnemonic standing room only for the foramina of the 3 divisions of the trigeminal nerve. The S corresponds to the superior orbital fissure for the V1 branch, the R corresponds to the foramen rotundum for the V2 branch, and the O corresponds to the foramen ovale for the V3 branch. Pause. Briefly cover these and meet me on the next slide for a flash quiz. Alright friends, it's time for a flash quiz. The question reads that a patient presents to the clinic complaining of eye pain and a foreign body sensation after he reports being scratched in the eye by his cat. The patient is diagnosed with a suspected corneal abrasion. As the physician attempts to remove debris from the eye with water, the patient's eyelids keep closing. The efferent limb of this reflex arc is also responsible for what function? A. Sensation to the anterior 2/3 of the tongue. B. Sensation to the posterior 1/3 of the tongue. C. Taste to the anterior 2/3 of the tongue. Or D. Taste to the posterior 1/3 of the tongue. The correct answer is C. The question asks for the efferent limb of the corneal reflex arc, which is carried out by cranial nerve 7, the facial nerve. The facial nerve is responsible for taste to the anterior 2/3 of the tongue, while a branch of the trigeminal nerve, the V3 mandibular branch, is responsible for sensation to the anterior 2/3 of the tongue. Looking at the taste and sensation aspects and innervation of the tongue in the image on the right, you can see how test makers could use the tongue to test cranial nerves 5, 7, 9, and 10 within reflex arcs in relation to sensation and taste of the tongue. This would be a good, complex way to test your knowledge of cranial nerve reflexes, and honestly is what I would do if I were them. So I wanted to design this question to give you guys a leg up on test day. Let's go. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Make sure to use the rule of 4s to locate the level of the brainstem where key cranial nerves are located. For the midbrain, cranial nerves 1 and 2 are above it, while cranial nerves 3 and 4 are located within the midbrain. Cranial nerves 5 through 8 are located in the pons, and cranial nerves 9 through 12 are located in the medulla. To assess the health of these brainstem regions and nerves, use cranial nerve reflexes. For the midbrain, assess the pupillary light and accommodation reflexes that involve cranial nerves 2 and 3. For the pons, assess 4 reflexes: the corneal and lacrimal reflexes that use the V1 branch of cranial nerve 5 and cranial nerve 7 or the facial nerve, the jaw jerk reflex, which uses the V3 branch of the trigeminal nerve, and the vestibulo-ocular reflex, which involves cranial nerves 3 and 4 in the midbrain, along with cranial nerves 6 and 8 in the pons. To evaluate the health of the medulla, use the gag reflex arc involving cranial nerve 9 and 10, the cough reflex arc with cranial 10 only, or the apnea test. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there's a great big beautiful tomorrow.